Yeah, good evening, ma'am.
Yeah. Should I test my slide thing so one doesn't fumble? Are we okay with sound?
Yes, ma'am.
Okay. So remind me, because I've forgotten all the share screen stuff.
Uh,
Can I go through it once, please?
Madam, this is a green button share. You look at down.
Where? I've got at the bottom.
Participants chat,
Yeah, so participants chat,
raise
raise
hand,
hand,
then
share.
share.
Okay.
Just
So
click on it. You keep your file open.
close, let me close. So you're saying I have a lot of files I should close, no? I don't know what this is. Sorry, I need to go and find that file. It should be on my desktop. Okay. So I just minimize it and keep it on the side. Yeah.
Yeah, just you press the share button, and then
So once I do the share button,
you can see in the tray your file. You can see.
I can't.
Click on that and share.
Where? I mean, I'm seeing here, but are you seeing it? No. Okay.
No, I can't see it.
Okay. Now.
Yeah, it just
Okay.
came.
And then for me to stop share is just there. Yeah?
Yeah.
Okay. Fine. Hi, Cherna. Hi. Nice to see you. Oh, is your mute? Right. Let me see if I can hear you.
Yeah.
I think you need volume a bit more up.
Okay, I'll just put the volume.
Because... Hi, Archana. I'm feeling nostalgic over here to our those COVID days. Do you remember when
Much we did in COVID, those
I know
this.
it's kind of reminding me of those days.
And
For
that was very popular. Wherever I'm going, no, during my campaign, I always find one or two people talking about it, and they say, "Ma'am, yes, we know we have attended your courses." I think about 1,200 odd people
we had at least exposed them.
yeah,
So that was really good. And good you've started this
yes,
focus series. I
yeah.
think
And
it's nice to take a niche topic and just talk about it. Which are the other ones you've done?
we have done endometriosis, we have done PCO, we have done C-section, we have
Huh.
done aesthetic and reconstructive gynecology. And I think we just take just one focus. We have never had a mixed topic. One is like hysteroscopy, only
So
hysteroscopy.
one's gynae, one's obs.
Yes, that's what we are doing.
And like how many of them are there?
We are doing it, actually, we were doing it on Fridays. But today, something, I was traveling or something, that's why they're doing it on Wednesday. So it's been going on since 1 year, last 1 year, it's been there.
Really?
Yes,
That,
last 1 year.
but
And
to find topics every Friday is quite
not
tough.
every Friday, once in a
A
month,
month.
every
Ah,
Friday.
okay,
So
okay.
12, like 12 Fridays gone in that. And then I'm doing another series, Inspire. And Inspire is with infertility topics. And
Okay.
one series which we are doing is a genosis. And that is again a mixed topics. And one is fertilogics. So four series are going on. So like my all Fridays, like 2 Fridays in a month and 2 Wednesdays in a month. So
There's
all
quite a
four,
bit other than the general stuff, no? Our
yeah,
sales stuff, which is
yes,
also
yes. So how is everything with you?
uh, we are at that time where you think, should you do more or less? So we've taken on this FMFI responsibility. So that is something that to get the certification process out and things is a little bit taking up the time. Other than that, pretty much of a muchness, really.
Okay.
But how is your grandbaby doing?
Oh, she's fantastic. She has now become like a very dancing doll. She's now nearly 10 months, so she just keeps dancing and doing the crawling in the house. So
Oh,
it's just so much fun. So
I
much fun
you-
observing her.
it is kind of
Oh, I'm
refresh you.
traveling a lot, so I miss her much, but I have to travel. I was talking other day to somebody. I said, "Well, I lose my practice time and I lose home
Uh,
time." So
mm,
somebody was very quite, she said, "Madam, you've done enough of practice. Practice बहुत हो गया. अभी ये दूसरा भी कर रहे हो ना? So not everybody is doing this. So yeah, just enjoy this journey also." I said,
that's
"Yeah,
what
it's fine."
that's what our kids tell.
Yeah.
My kids are non-medics, so they find it stupidity that you should still want to work at this age. I mean, they can't understand it. Hi, Anjum. Anjum was very efficient, Archana. She was really good in chasing up.
Yeah, chasing.
So
Oh, she's a gem of a
yeah.
person. Anjum and Rupali. Both of them have been doing it. I think it is their 14th or 13th focus series.
Uh,
And she's made a nice Excel sheet of everyone who has attended and who all, and she's connecting with them also.
oh, that's
So
very good.
both of them,
No,
both of
but
them are.
no, I appreciated you, Anjum, kind of chasing up because sometimes you sort of forget.
Yes.
So it was really,
Rupali is also one person.
oh,
So
good.
there is
Yeah, no.
always problem with Rupali.
Madam. Good evening, Dr. Anita ma'am, Archana
Hi,
ma'am.
Rupali. It
Hello,
was nice to
Charna ma'am.
work
Good
with the
evening. We are so
team.
lucky to hear pearls of wisdom today from all of you.
Don't know about
How
that.
are you, Jarna? How is everything with you?
Fine. She is always busy doing something or the other. Hi, Shelley. Nice to see you.
Hi, Shelly.
Hello, ma'am. Hello, everyone.
Hi. All good. All good. Good to see. We keep our
Nice to
program
see
very crisp and very, like focused. So that
you.
it's like everybody who attends also enjoy, and then those who are uh, speaking also enjoy it.
Mm-hmm.
So how
Yes,
is weather in
all the
Delhi? It is raining in Indore.
no, it's quite nice, I think. It's goes
Coming
up.
to Indore
But
is
I think
great.
that don't you feel that we go from indoor to indoors? I can't remember the last time I actually walked outside, which is terrible. I don't know. I mean, do you
I
get
don't
out?
know if somebody asks me what is the weather today, like I said, I will come to know when I sit in my car and go home.
That is a thing.
Otherwise, I wouldn't know.
I'm coming to Indore in the end of June, ma'am.
Mhm.
You're doing another darshan?
No, not darshan this time. Just,
Oh,
just
another trip. She goes
another.
and cleans out. She sort of buys 20 saris at a time.
No,
That's
I'm
the
going to
Indore
get
trip.
Ayodhya Fort Maheshwar this time.
Then you'll go mad there because that's a beautiful place. But anyway, so are we nearly 7:30? Should I
Yes, yes, I think
let's
Anju, we just have to check with Dr. Our chief guest.
Yes, ma'am. Madam is joining actually. She received the link on WhatsApp.
Hmm.
I think she should be joining anytime.
Yeah, so 7:30, then we begin at 7:30.
Yes.
Okay.
Hello, Dr. Anjum.
Hello, ma'am. How are you, ma'am?
Good.
Yeah, ma'am has joined.
Hi, good evening. We have time. We have 2-3 minutes
Yes.
to start. Yeah, I just.
Good evening, Dr. Neena. How are you?
Hi, good evening. I'm just working in the office. Can I just attend on some people and I'll come back in 2 minutes whenever you tell me.
Okay, no problem, Neena.
Hi, Dr. Archana, how are you?
I'm good, Dr. Neena. I'm very good. Good to see you all here, and
Yeah.
good that all of you have accepted the invitation to join in.
Yeah,
And Ankita, congratulations to you. just
Thank
cleared
you.
her MRCOG, and she put it on the group. She has cleared MRCOG. I roped her in. I said, whosoever is MRCOG, come on this group.
Thank you so much, ma'am.
She's from Indore only, no?
Yes, ma'am, I'm from Indore.
Yes.
Congratulations, Dr. Ankita.
Thank you so much, ma'am.
Because passing MRCOG part 3 means really tough, huh? Nowadays with the OSCE and going to all those 14 stations, it is tough.
I think passing rate of this time MRCOG was also very less, isn't it, Dr. Ankita?
Yes. Yes.
Ma'am, it was 62 this time.
But the pass percentage was very less. Lot of them.
Pass percentage, I've heard it was not that higher.
Yes,
It
ma'am.
used to be around 22, 23.
Yes, ma'am.
So I think it's an exam. You feel suddenly different.
I have some
Yeah.
points where you cannot pass the candidate if she says this. So those points when you mark, you really you're not able to pass anybody. Like I've been an examiner for almost all the exams that have happened in India. I'm seeing gradually they're making it tougher little bit.
Okay.
They have something in the answer sheet where they will say that if yes, not say this, then you have to fill them.
Yeah. So there are 3 points, no? One is like it must be said, and if there are some points, if they are not included, like you are giving aspirin and asthma, you don't mention that it is a contraindication, then you can't pass. There are very stringent criteria.
Yes, ma'am, that's true.
I feel it's a technical exams, madam, more than, your knowledge assessment. Knowledge assessment happens in your part 2. Part 3 is totally technical. You know the technique, you crack it.
That is true for everything, Rupali. Any exam.
Part 2 is, no, madam, itna hai, bapre vast. It is too much. I felt the part 2 was tougher
Difficult.
than part 3. Part 3 I sailed.
Part 2 has a clearing rate of only 30%, and part 3 usually 40 to 60% people clear at one go.
Yes. And part 3, it helps because when you give it a little later now, because you're already versed by talking with patients and all. So, jo younger generation, they find it a little difficult. But those who are already in practice, I gave my part 3 in 2021. So, मुझे वो easy लगा. But part 2 was, oh my God. वो talk और GPG करते करते I was like,
Is always easier for persons who are practicing, and part 2 is easier for those who just cleared the exam. They are in habit
Correct.
of bugging things again and again. So
memory
it's
भी sharp रहता है उस time पे.
But part 3 will really help us in communication. After that, our communication with patient changes completely.
Completely. Definitely.
So I think it is 7:34, Rupali. Nina has joined.
हाँ,
So
madam,
can
start
can-
करते हैं.
Start with
Yeah, you can start.
Yeah, Sudeep sir, we can have this.
Yeah, we'll start with the lamplight.
Yes,
We'll
thank
go
you.
live now.
Nina, are you going to Ashri, Nina?
Yes, I am. Yes, I'm going to Ashri.
Yes.
I
Everybody.
think you all are there for the India Day as well.
Yes. No, I'm not coming.
Oh, you're not coming?
Oh no, this time it's my election campaign year, so
Yes.
I'm not going internationally. I'm just traveling national.
But are you not going, Nina?
No,
To
I'm not.
India Day, I meant.
No. You going?
No, I'm not. But I thought if you're there, Nina, then you should.
I
What
am.
you
I'm
want
going to
to
Ashri and I'm going for the India Day as well.
you
You
are.
know, anytime.
Because
We
you-
booked our flights one day. Me and Amit, we just booked our flights accordingly to be there.
because
So we're
you'll
there.
be
on the-
representing North Zone. I don't know who
Yes,
else is
I'm
going
there.
on.
I'm there.
Oh, good. Good. Great.
And
Thanks.
from Northern, we'll have good attendance, don't worry. Dr. Mamta is also there, Dr. Shweta.
That's
So
only
Shweta is going. Me, Shweta Gupta, and who else? We
Dr.
all are at
Mamta is
Ashri.
also going.
And I think there are a lot of our juniors who are also attending Ashri. So I think most of them are the fresh ones, who those junior people from
Outsourcing.
RCUG.
Okay, that's nice. So, Dr. Rupali, shall we start?
Yes, ma'am. We should start.
Yeah, we go live now.
Sir, we can start.
Till days.
डेटेड बता दूंगा सेम डेट्स पर
Thank you, Sudeep sir. A very warm welcome to all the esteemed faculty and all the delegates who have joined us today for this webinar. It's a collaboration between AICC RCOG West Zone along with AICC RCOG North Zone. And the focus of focus series today is the fetus in the first trimester. We all know first trimester is much more than just beginning of the pregnancy. It's a window during which foundations of the fetal life are laid. And early fetal evaluation not only reassures parents, but also offers opportunities for timely diagnosis, intervention, and improved outcome. With that in mind, we welcome you all to this webinar. At the outset, I would like to, it's my privilege and honor to introduce AICC RCOG North Zone Chair, Anita Kaul ma'am.
Thank you. Thank you very much, Anjum.
But I would still like to read out ma'am's CV. CV, please. Anita ma'am, we all is senior consultant. She's a clinical coordinator of Apollo Center for Fetal Medicine and Therapy, New Delhi. Ma'am is currently the head of Apollo Center of Fetal Medicine. She is chairperson IRC, RCOG North Zone. She's also founder trustee of India. Sound simulated. I have also attended, found it very helpful. Thank you, ma'am. Her main interest remains the great obstetric syndrome and prenatal screening. Ma'am has more than 40 plus publications and she has evaluated screening protocols for the Indian population in preeclampsia, growth restriction, and preterm birth. I welcome you, ma'am, and request you to kindly address this webinar.
Thank you so much. It's really my honor to be invited for this, and and I think, Archana, it is such a wonderful idea that you had of getting the zones to work together and to collaborate, because I think that is the way forward. And you've always been someone who believes in teamwork and working together. It's a pleasure to be with my colleagues, Jharna and Shelley over here, and to be with our AOGD president as well, who's also a member of the North Zone. I appreciate these focus series, and you've chosen a topic, Archana, which is very close to my heart, but also I think of very practical significance for the obstetricians. So I think it'll be nice for us to deliberate on that and then have some expert comments from the chair. So thank you very much.
Thank you, Anita ma'am. May I now request Dr. Rupali Dharwadkar to introduce our program director, Archana Baser ma'am. Dr. Rupali is a consultant in obstetrics and gynecology at Surya Hospital, Mumbai, and she's MSM RCOG. Rupali, kindly do the favor.
Thank you, Dr. Anjum. A warm welcome to all the esteemed faculties today. We're really very happy and it's so nice and we're looking forward to all the talks today. Dr. Archana Baser, ma'am, we all love her and we all know that she's a visionary leader in women's healthcare. Ma'am is a consultant obstetrician and gynecologist and she's the director of the Akash Hospital in Indore. Ma'am we all know that she has a Guinness World Record holder for the surgery which she has done for the fibroid uterus. Over 3 decades of dedicated service, ma'am has in the field of obstetrics, gynecology, infertility, and women's health. She's a renowned academician, clinician, and a national faculty. She's a former Vice President, FOXI 2020, Chairperson MPSR 2025-27, and currently ma'am is a fellow representative AICC RCOG West Zone. We also know that ma'am is standing for the presidential candidate. She is for the FOXI 2026. We wish ma'am you have all our best wishes and success will be yours. Ma'am, we want ma'am to introduce and call upon our chief guest today.
A very good evening to everyone. Rupali, thank you so much for kind introduction. And at the outset, let me thank our RCOG Waste Zone Chair, Dr. Purnima Satoskar, for giving us this opportunity to hold this focus series from the platform of Waste Zone. When we did our first webinar with the Waste Zone, we had all the past chairpersons of Waste Zone as the chairpersons or as a guest of honor, and all echoed the same thing that we should have uh, different zones being involved in this focus series. So we have involved South Zone in the past, we had Dr. Umaram, and now we have involved the North Zone so that we cross connect, we know each other, though we know each other, but others also know. And this is a focus series, means just focus one topic we take and 3 or 4 lectures on the same topic so that everybody goes home with some take home messages. And I'm really glad today that we have Dr. Anita Cole, chairperson of North Zone, and chief guest Dr. Nina Malhotra. She is AOGD president, as well as she is the head of department of All India Institute of Medical Sciences. And we have our other speaker along with me, Dr. Upma Saxena, and all the 3 chairpersons, Dr. And Angela, she will be joining soon. And Dr. Shelly is there with us. And I'm really happy that the newcomer, Ankita, has been involved by both of them, Rupali and Anjum, as a master of ceremony. So this is my proud, and Jharna is also here. Jharna has joined, I think, long back, but in between she disappeared. So Jharna is here. And basically, I mean, Nina Malhotra, I found a very friendly person, a very down to earth person. Means she doesn't have any, what I should say, air of All India Institute, head of the department. She's very, very approachable person. If you call her, and she doesn't pick up, she will either send you a message or she'll call you back. So that's a quality in Nina. Nina is MD, DNB, FRCOG, professor and head department of OBGYN AIMS, and she's expert member of National ART and Surrogacy Board. She's president of IFS, and she has a research grant from ICMR and IPOS, Myomet, and Fellowship of Commonwealth, Boy Scout, ICMR DHR. She has awards from RCOG London, Overseas Funds Sir Malcolm Blake 2019, and Foxy CS Don Korean Research Award. And I think the publication number is really, really so high because I mean they are great academician, 172 in peer reviewed journals, and she's running a very good program for the Foxy on the ultrasound. I think this is a very it has a very tremendous response. So over to you, Dr. Nina, for your words, advice, and on this focus series.
Good evening, everybody, my dear friends and colleagues in the past, Dr. Anita Kaul, Dr. Archana Basir, all of them, Dr. Jharna, I can see many names. Thank you so much for calling me. I feel a little shy and I feel to be called as a chief guest. I'm part of you people, suddenly being a AOGD president, yes, you do get that feeling. But when I heard this very enthusiastic, initiative on early pregnancy, I think I was very delighted because now that I would say as a chairperson of the Imaging Science Committee for the last 2 years, I've been going across the country doing a very skill-based training program called POISE, which I had an acronym for preventive obstetrics through imaging skill enhancement. And trust me, we go to medical colleges, we go and train the juniors, teach them the wisdom and the power that ultrasound has, an early ultrasound which gives them the potential to pick up so many problems that could lead to complications, right from a uterine artery Doppler to doing the NTNB to cervical end measurements. And I think that's where the wisdom lies when we work in sync rather than silos. And what a good opportunity when the West Zone meets the North Zone, and there are specialities and subspecialties getting together. So once again, thank you very much. I'm also very delighted to say that my dear friend Dr. Archana is taking up the elections as a president of Foxy. I wish her good luck, and I think all of us should stay strengthening her, giving her the support, and we would love to see her come back as the president of Foxy. All the best to you, Dr. Archana, and a very, very congratulations for taking this initiative of Focus series. Thank you very much.
Thank
Okay.
you. Thank you, Dr.
Thank you.
Neena, for the kind words, and thank you for your wishes. And the most important thing is, like, you are doing the skill transfers. I think it is very important that, I think you must have read and you must have known when one of the RCOG president was asked which is the biggest innovation of this century. He said ultrasound, ultrasound, and ultrasound. So this is, we know that ultrasound has changed our practice, and it is very important that even in the medical colleges we impart that skill and teach them how really the complications can be prevented and how really we can save the babies and save the mother. And if there is any anomalies which can be picked up in the first trimester to save the trauma to the couples. So very, very rightly said Dr. Neena that it is very important that ultrasound skills are to be imparted and to everyone who is joining OBGYN. So thank you. Thank you for joining us. And I think we also did one course with FMF and Foxy in Corona. If you might have heard of it, and me, Dr. Anita, and Dr. Meenu, we trained about 1,500 obstetricians sitting in the remote places online and with a very strict exam schedule, which was done by FMF, and it was very rewarding when you go and meet the people there in the different parts of the country in the Foxy Society. They remember you that yes, I attended your course and I really found it useful. So thank you very much, and all the best to you as well for your next year as a imaging science chair. Keep continuing the imparting these skills to everyone.
Thank you so much.
Thank you, ma'am. Now we'll be starting with our scientific session. It is my privilege to introduce our esteemed chairperson for today's session. May I have the slides, please? Yes. So I'm honored to have Dr. Angela Anija ma'am. She's MD, DNB, MRCOG, FRCOG. She's the Executive Director at the Women's Hospital, Nehru Enclave, New Delhi. She's a Senior Consultant Obstetrics and Gynecologist and MAS Gynec Surgeon at Fortis, LAFM. She's a Vice Chairperson, IRC, RCOG, North Zone. She'll be joining us, and thank you for joining us, ma'am. Now I'll be introducing our second chairperson. She is Dr. Shelly Arora, ma'am. She is MS, DNB, MRCOG, FMAS. She is the member, representative, and secretary, IRC, RCOG North Zone. She is the convener of MRCOG Part 3 and 2 courses in Delhi. She is clinical examiner, MRCOG Part 3 exam. She is a senior consultant, Ops and Gynae, Cloud9, Vikaspuri. Thank you for joining us, ma'am. We are honored to have Dr. Jharna Behura, ma'am. She's MBBS MD, MRCOG, FRCOG. She's the head of department, Ops and Gynae, Kasturba Hospital, Delhi. She is fellow international representative, RCOG North Zone. Thank you for joining us, ma'am. Now we'll be starting with our first presentation. So I'll request request our first chairperson, Dr. Angela ma'am, to introduce our first speaker, Dr. Archana Basir ma'am. The topic is biochemical markers in the first trimester.
I think Angela will be joining a little late, so we can ask Dr. Shelly, but I'm already being introduced. So I think we can straight away go with the topic.
Yes, ma'am.
What do you say, Dr. Shelly? I think we should start.
And we welcome you again formally for your next talk. And you need no introduction. And we wish you all the best for your next year's election, ma'am.
Thank you so much, Shelly. It's always
And
nice.
it's a great initiative which West Zone has started. And this shows our future president's collaboration with all the local committees will really be in good hands in future for
Very
sure.
true.
Thank you. Thank you so much. Thank you. So may I be allowed to share my screen, please? So I think is a very good evening again. As our focus was today, Foetus. So what topic like Anita is going to be taking on the NT scan beyond NT, and Dr. Upma is going to be taking about the invasive and could CVS intrauterine transfusion. I thought it is very important that we talk about the biochemical screening, look beyond low and high risk report. Because what is happening today, only I had one young girl in my 31-year-old in my clinic. Somebody read her report it was written as a low risk, while her figure, you have to really look at the figures and the full report. So that somehow got missed out. And when we were little, she came to us at 21 week. We got her NIPT done, and that showed the high risk for the Down syndrome. And just today only I did her MNU. So I'm going to come back to that again. So let's for everyone's information, what is screening? Screening is a low risk population is to identify the individuals at high risk for a particular disorder. And ideal screening should have high detection rate, means how many affected babies the testing is picking up, and false positive rate should have low false positive rate, so it doesn't pick up the right baby and label it as a problem. Now, why to screen? The incidence of chromosomal abnormality is quite high. It is 1 in 300, and the most common chromosomal anomaly being the Down syndrome, and the risk is 1 in 200. And 90% of young women are affected, and 95% with trisomy 21, 13, and 18. So if you look at the overall risk of abnormality, it is 1 in 150 live birth as per ACOG 2018 data. Now, what are the risk factors for chromosomal anomalies? We know the increased maternal age, background risk, and a priori risk. Parental translocation, Robertsonian translocation, previous pregnancy with chromosomal abnormality, and the risk decreases with the increase in the gestational age. Now, maternal age and T21 relation. Risk increases with the maternal age. You can see here in this graph, as the maternal age is increasing, the risk is increasing. And the risk decreases with the gestational age. The gestational age goes up, the risk goes down. Maternal age goes up, the risk goes up. So 30% of Down fetuses die between 12 to 40 weeks. In our country, not everybody comes for investigation, for screening, or even for the diagnostic, or some do not even come for the ultrasonography. So many a times we don't know the cause of the IUD. So maybe there is a cause for IUD, that is the Down syndrome. So 30% Down's babies are die between 12 to 40 weeks. Now, if you look at maternal age and trisomy 18 and 13, so the rate of fetal death between the 12th and 40 weeks is about 80%. So this is the rate 21. This is the trisomy 18 and this is the trisomy 13. So look at the maternal age. As the maternal age increases, it increases the risk of all kinds of aneuploidies. Now, what are the other defects which you should be looking for? One is the Turner syndrome. It's unrelated to maternal age, and the rate of fetal death between 12 and 40 weeks is about 80%. And the prevalence is about 1 in 1500 at 12 weeks and 1 in 4000 at 40 weeks. Triploidy is unrelated to maternal age again, and the prevalence at 12 weeks is about 1 in 2000, but it is highly lethal and it is very rarely observed in the live birth. What is most important when you see a report of the biochemical report, the double marker, triple marker, or quadruple marker, it is very important that all of us should start looking at the individual biochemical markers. Most of us, what we are doing, the report, the lab persons are giving us a graph. We just go to the graph, and in the graph, they will say, it is a high risk, it is a low risk or intermediate risk. And they put that 1 in 200, 1 in 250, and we just take it into and we do our patients counseling as per the report being printed. I think it is time we should look at the individual markers like placental products, beta HCG, PEPE, inhibin A, hyperglycosylated HCG, PLGF, and look at the fetal product, that is maternal serum alpha fetoprotein and unconjugated estriol. Now, beta HCG, it is produced by syncytial trophoblast cells of the placenta, and maternal serum HCG peaks at 8 to 10 weeks and then declines to reach a plateau at 18 to 20 weeks. And it helps in placental angiogenesis. uterine relaxation and growth of the fetus. So this is the free beta HCG levels. If you see here that it is peak here and then it starts going down. Now what happens? Another thing is PEPE. It is produced by placenta. First trimester PEPE levels increase by 30 to 50% per week between 10 and 13 weeks of gestation, and cutoff is 0.5 mom. Now, PEPE plays an important role in placental growth and development. It increases the bioavailability of insulin-like growth factors, which in turn mediates trophoblast invasion and modulate glucose and amino acid transport in the placenta. If there are low levels, risk of FGR, the fetal surveillance will be required. So this is what is important, that you look at the PEPE value, and if the levels are low, irrespective of whatever is coming on the graph for the Down syndrome, for trisomy, if the levels are low, it is suggesting that there is a risk of FGR. So that is, we have to understand, and then risk of the hypertension in pregnancy, and sometimes it is a marker for the preterm delivery as well. Now, concentration of PEPE with the gestational age. Concentration increases exponentially with a doubling time of 3 to 4 days during the first trimester. It keeps doubling the PEPE with the gestational age. Look at the maternal serum alpha-fetoprotein. Alpha-fetoprotein is a major plasma protein produced by yolk sac early and later by fetal GIT and liver, and maternal plasma levels peak exponential rise between 15 to 20 weeks. It is used as an important marker in second trimester screening as levels are reduced in trisomy 21. So this is the alpha-fetoprotein mean concentration of AFP in maternal serum, amniotic fluid, and maternal serum. So look at the value: fetal serum, amniotic fluid, and the maternal serum level of MSFE. Now, using an MSFE level of 2.5 mom is the upper limit of normal, which yields neural tube defect detection rate of 90% for anencephaly and 80% for spina bifida, with false positive rate of 2 to 5%. Targeted ultrasound is next step after an elevated MSFP, and it increases the sensitivity to 97% to 100% to screen neural tube defects. Now, unconjugated estriol, it is a steroid hormone, requires fetal adrenal, liver, and placenta for synthesis, and it is used in quadruple screening test and second trimester as levels are reduced in trisomy 21. Inhibin A, glycoprotein, it is produced by placenta during pregnancy. Two isoforms, inhibin A and inhibin B. Levels increase until 10 weeks and then stable up to 25 weeks, and elevated levels more than 2 moms predicts pre-eclampsia in pregnancy, FGR, and miscarriage and aneuploidy risk. So this is the serum screening chart. First trimester, do NT, do dual test, beta HCG and PEPE. Second trimester, triple test, alpha-fetoprotein, beta HCG plus conjugated estriol, quadruple test, AFP plus beta HCG, unconjugated estriol, and inhibin A. Then first trimester combined screening, do the biochemical screen markers, serum analytes, dual marker, and ultrasound markers, CRL, 45 to 84 mm, do the nuchal translucency, and based on maternal age, biochemical and ultrasound marker, final combined risk of aneuploidy is calculated. Now, what is very important is a pre-test counseling. You have to explain about the condition to be tested. Counseling should be informed and non-directive. Cafeteria approach is very important, that you do a cafeteria approach, right? It is very, very important. And limitation and turnaround time of various tests should be explained. If the patient accepted screening, she should be offered a proper one prenatal screening approach. You should not be offering her a array of investigations. What is happening? Do a test, double marker also, quadruple marker also, or NIPT also. No, this all discussion should be done in the. I'll just take 1 minute. So all these discussions should be documented in medical record.
Archana is completely right about this. But generally speaking, all institutes tend to have for that area, they decide that this is probably the best way of approaching things. So technically, the combined screening should be offered. But I mean, it'll be interesting to get the chairs to comment on this. Chair, sorry, you're back.
I think I'm back here again. Just, overuse of computer, just the battery was finishing. So I said, let me charge it before it shut down. So, what happens? The patient wants to know what is trisomy, what is aneuploidy, what is, 21. Today only when I said that I did a amniocentesis, she wanted to know what is this Down syndrome, what is this trisomy, where the extra chromosome comes from. So you really have to give a thorough, information to the patient before you are embarking upon any invasive testing or any biochemical screening. I think there should be a one person designated who is doing the counseling of the couple when you are doing the pre-test counseling, because if the result comes low risk, fine, but if the results comes intermediate or the high risk, the couple sometimes, and never, it is our policy, we never inform these reports over the phone. Patient has to come personally to collect the report, or means at least they have to talk to the doctor. So this is the record of the information, and then press the calculate. These are the available. Calculating the risk is available. You can put the data like mother's date of birth, weight, and then your NT, crown rump length, and you will get a figure that what is the risk. Now, what is mom? Mom values are calculated by dividing an individual marker level by the median level of that marker for the entire population at that gestational age in that laboratory. So mom is patient's result divided by median result. So medians are determined by the laboratory for each marker across all gestational ages required for a given test strategy. So, for example, Mrs. X is 13 weeks gestation with alpha-fetoprotein 60 nanogram per ml. Her medium AFP is 30 nanogram per ml. So it will be 2 mom. That is, she had alpha-fetoprotein value 2 times more than the average population. So that's how you do the calculation. So this is a 0.5 mom. This is more than 2 mom. So this is how you will be plotting, and this is the average. And this is like somewhat less mom, and this is somewhat more. So these are the graphs which shows you that where the mom value is there. So this is normal distribution curve, or what you call is the Bell's curve. Now biochemical markers in the first trimester, free beta HCG, PEPE. So free beta HCG, euplite 1 and 1, trisomy 2, 0.5, trisomy 18, 0.2 and 0.2, trisomy 13 is 0.3 and 0.3, and Turner 1.2 and 0.5 mom. So each measured level is first converted to a multiples of expected normal median mom and specific to a pregnancy of the same gestation, maternal weight, smoking status, ethnicity, and method of conception. It is very important that it is an ART pregnancy, and you have to put the right age. Sometimes in a donor age has to, if it is conceived by the ovum donation, you have to put the age of the donor, not the age of the recipient. Otherwise, it will be a false report. The serum markers in Down report, Down syndrome, if you see, you are doing the, sorry, I just moved it. So Down syndrome, first trimester, this is the normal and this is the Downs. So PEPE and you are doing the beta HCG, and this is the quad test reports. Now combined test, step 2, measure NT correctly. I think Anita will be talking about it. But NT measurement and the correct position of NT is important. Sometimes if NT is not visible, people are doing it in a, not the right position. They just report that it is normal or it is less than 3 is considered normal always. But that is not true. You have to plot it in a graph. 3 may be normal for 26-year-old, but 3 may not be normal for a woman of a higher age. So there is nothing like that you have an absolute value. You have a graph and you have to plot it on that. So measure NT correctly. Each NT value for a specific CRL has a likelihood ratio. Larger the NT and higher is the problem. Now pattern of results. What happens? In the Down syndrome, AFP will be down, HCG will be more, and E3 will be less. And underestimate gestational age, trisomy 18, AFP will be less, HCG will be less and E3 will be less. And spina bifida, we all know that AFP will be more and HCG will be normal and E3 will be normal. And in anencephaly, AFP will be raised. We know that maternal serum alpha fetoprotein will be raised in anencephaly. HCG will be normal and conjugated estriol will be low. So this is a chart which is very important, that if you can memorize or keep it under your table, so that once the report comes to you, you can just see the individual value and see where the AFP value is. And I think this is too busy a slide. Patient details and risk factor, maternal age and prior risk, individual markers and cutoff, ultrasound anti-measurement cutoff, and risk of T21, T13, and T18. So this is how a priori risk and a final risk is being calculated. The result of screening test has a probability for Down syndrome. Like say if you say in this pregnancy, it is never, whenever you are giving a report to the patient, you will never say it is normal. You will always talk in terms of risk, whether it is a low risk, whether it is an intermediate risk, or whether it is a high risk. Never ever write that it's a normal value or normal risk. So refer, if it's a screen positive, high risk, more than 1 in 250, refer for genetic or fetal medicine consultant, offer invasive testing. NIP, non-invasive test, is offered only if not willing for invasive test. Screen positive, intermediate risk, refer again to fetal medicine unit, or if you yourself are counseling, that's fine. And assessment with new markers, contingent screening with non-invasive prenatal screening. And screen negative, low risk, less than 1 in 1000, detailed ultrasound evaluation at 18 to 20 weeks. So they are like screen negative, low risk patients, where you can just do a detailed ultrasound and discharge them from screening protocol, and routine antenatal follow-up can be done, because you cannot bring all the women for antenatal checkups very often. So these are the two groups where you have to really focus more. And these are the AOGD and Foxy fetal medicine recommendation of 2017. So 11 to 14 scan, do a combined test, cutoff 1 in 100 invasive, 1 in 100 to 2500 do an NIPT, and more than 1 in 2500, you don't have to do any further testing. So additional first trimester marker is absent nasal bone, reversal of ductus venosus, and tricuspid regurgitation. So increase NT, reversal of ductus venosus, and tricuspid regurgitation. Now, they are highly sensitive and specific for trisomy 21. And each of these markers, sonography markers, can be incorporated into combined screening by maternal age, fetal NT, serum-free beta HCG, PEPE performance in detection rate 93 to 96%, and decrease in false positive rate is 2.5%. But anything that you require a high expertise, and I think through the FMF platform and through the Foxy, we are, as we heard, that we are imparting skills, and we are giving the, there are courses where they are doing the NT, just to learn the NT and what all you can do at the NT time. I think that is going to make a change in the practices which we are doing, the obstetric practice. So these are the Down syndrome screening tests, and these are the percentage. When you're talking to patient and offering them a particular investigation, they might ask, madam, what is the percentage of picking up the problem? So this is a chart which will help. Like maternal age only screens out 30%, then age, serum biochemistry 50 to 70%. And we know that if you do fetal NT, NB, maternal serum marker, and PEPE 11 to 13 plus 6 weeks, it is 95% is the report. And this is detection rate of preeclampsia. I'm not going into that, because that I think in the next talk you will be listening to that when you are doing the NT scans, so you can pick up that which are the women who are going to have a preeclampsia. So I'm just skipping that. Triple market not done now. Low detection rate 65%, with false positive rate is 5%, and you do the quadruple marker. Now, why do you do quadruple marker? Because patient has missed the boat. She didn't come to you in the first trimester. At the first place, offer everybody first trimester investigation. So when it was not available, patient didn't come or didn't get it done, do a quadruple test. And an add-on test to serum integrated test and sequential screening. So second trimester screening performed at 15 to 16 weeks to 23 weeks of gestation. when first trimester scan was not done, and as an add-on test, and detection rate for trisomy 21 is 81%, while false positive rate is 5%. Now, combined screening, you can do integrated screening, sequential screening, and contingency screening. These are all integrated tests. So, like NT plus PPA, combined test, SWOT test, second trimester. So, these are the all tests. So, it has highest Down syndrome detection rate, 94 to 96%. And disadvantage is of the integrated test is long waiting period and difficult to call patient for second screening test. That's the only disadvantage. And serum integrated NT is not included. So detection rate is little low. It is 88% with false positive 5%. So these are the stepwise sequential testing, combined test, low risk, high risk, low quad test, to the final risk, low risk, and if do a high risk, do an invasive testing. So at the end of the day, if there is a high risk, do an invasive testing. So the advantage of sequential testing is it allows high-risk patient to avail immediate diagnostic testing if required, sensitivity and detection rate similar to integrated screening, and disadvantage is patient need to be called for second trimester test. And this is a contingent screening, low, no further testing, ultrasound, quad, NIPT, and then invasive test. So only a small percentage of patient having to undergo further second trimester testing. So our aim is, because our women cannot come, like second trimester or multiple times. So we have to offer them investigation or a method of screening, which can just on the first go or in the first trimester by just doing one investigation, just do a biochemical screening and ultrasound, can just do a screening of them that who is high risk and who is low risk. So then again, the screening in twins, dichorionic, monochorionic, first step is to identify chorionicity, dating, and twin labeling. Dating for spontaneously conceived twins, the larger CRL should be used to estimate the gestational age, and twin pregnancy conceived after in vitro fertilization should be determined based on date of egg collection or the age of embryo in days at the implantation, and twin labeling is very, very important. So this is the screening for trisomy in monochorionic twins. I will not go now. I think my time is running. First trimester screening for trisomies in pregnancies with the vanishing twins. It's a very interesting article by from the FMF and Professor Nicolaitis. So aneuploidy screening, maternal serum beta HCG and PEPE at 11 to 13 weeks gestational. They did in 528 pregnancy with vanishing twin compared to 5280 normal singleton pregnancy. And the effect of PEPE amount is larger when blood sample is taken close to the demise of the twin. So conclusion, first trimester screening for trisomy in vanishing twin pregnancy with an empty gestational sac or a dead embryo should rely on combination of maternal age, fetal NT, and serum beta HCG as in the single pregnancy. So these are again some studies. Now I'm just skipping this, and this is a service trial on talking about the integrated test, and I am just now going about fixed false positive rate, performance of maternal age, and various tests in the second trimester maternal serum combination in screening for Down syndrome. So these are the results, like where you get integrated 94% and you do combined 85%, quad and triple is also there. And then odds of Down syndrome after a positive test result based on data from the service trial. So I just will like to end with the case, just one case, 31-year-old female, which I just mentioned to you at the before. She has a previous LSCS, normal pregnancy, normal child, which is 2.5 years now. She's on regular antenatal care. She did NT scan, all normal. Nasal bone is seen. NT is within the range. No other soft marker seen. She forgot to give at the time of NT scan her biochemical screening. And she came back that, oh, doctor, I forgot this time my biochemical screening. Can I go for the quadruple marker? She did her quadruple marker. And when the quadruple marker was done, it came into the, it was an intermediate risk, but the company wrote the low risk. But still that patient and us were very keen on like getting NIPT. So we did her NIPT, and in an NIPT, it shows that she has a high risk for the trisomy 21 So we did her amniocentesis today and waiting the result. So sometimes some patients may get missed out, but it is very, very important that results are really seen with way too much care and interpreted properly. So first trimester combined test is equal or superior to second trimester screening. Best test is integrated test. Stepwise sequential screening or contingent test is beneficial. Quadruple test is reserved only when first trimester screening is not done, and dichorionic pregnancy specific risk is calculated by summing individual risk, and monochorionic is based on average of LR derived from the NT of both the fetuses. So thank you very much for patience listening, and I am seeking your support and vote for Foxy presidential election in year 2026. I'll be with you, I'll be for you, and I'm by your side, and I'm one of you. So thank you very much. And I think it is very important that first trimester screening is really offered to everyone and it is interpreted properly so that we do not miss out and we have to do the invasive testing very late.
Thank you, ma'am. Thank you, ma'am, for your insightful presentation. Now I request our chairperson to kindly share their remarks.
Thank you, Dr. Archana and RCOG West Zone for inviting all of us for this excellent, insightful presentation. I must say that, ma'am, you have completely very comprehensive talk you have given. I just want to put few points that yes, the first trimester has really helped us inverting the triangle, and it has give us the very crucial window for risk assessment and prediction of adverse pregnancy outcomes. Adding biochemical markers to these ultrasound findings and maternal factors have transformed the prenatal screening and enabled us detecting chromosomal anomalies and predicting the pregnancy complications for the third trimester. Just a few points to be highlighted, as you have very well highlighted that don't just look at the low risk or the high risk given by the lab, but do look at the individual moms of each hormone as well, because it will also tell us that isolated high HCG levels or isolated reduced PAP are associated with few complications and FGR risk of or preeclampsia risk in third trimester. So by adding just ecosprin would help us reducing those risks. So do look at those individual reports of each mom and choosing the lab wisely also is very important, I feel, because using standardized method like Delphia or Roche like these and not just relying on any lab doing these PAP mom monitoring with not a very standardized method they use. So each lab does not use that. And in my practice, we have been integrating the first trimester quadruple marker, and you very well mentioned that we have to give a cafeteria approach and explain the patient very well that what all options are available with their detection rates and false positive rate being documented on our medical records. That really helps patient to even finalize the monitoring which they required and recommending them the well monitoring the test easily. Thank you for the well-chosen topic for this session, ma'am.
Thank you, Shelly, for your kind comments. And I think very rightly said that we have to give them option, they have to choose, because when it comes to the cost, sometimes people don't choose NIPT or NIPS because it is like many times expensive. But if we explain, they accept. So that's the thing. So now I think if there are no questions, I think we move over to another talk. So I'll ask Rupali and Anjum and Ankita to take it forward. Thank you, Dr. Shelly.
Okay. Thank you, ma'am. I now request Dr. Jharna Behera, ma'am, to introduce our second speaker.
But I've been introduced. So I'm going to be like Archana and say that.
At least we should speak a few words. I mean, she doesn't need any introduction. She's such a brilliant personality. But currently, she's the head of Apollo Center of Fetal Medicine at Indraprastha Hospital. And she's also the chairperson of the IRC RCOG North Zone. And she's the founder trustee of Fetal Medicine Foundation India, whose mission statement is to impart ultrasound training to OB-GYNs. And I'm really happy to tell you that she has been training government hospital doctors to do ultrasound themselves, because from now on, or maybe a few years back, we realized that the radiologists are no more interested in ultrasound in the government hospitals. They want to do the CT scan and MRI imaging and interventional, and more focusing on interventional on gynae ultrasound like adenomyosis, and all they want to do those interventional microwave ablation, etc. So now I feel every doctor should be trained in to do these ultrasound, and at least level 2 ultrasound. And I'm really lucky to be trained under her.
You've been a wonderful student. I mean, you also got your ISWAC certification, so that's quite an achievement, I think, Jarna.
Yes,
So thank you all very much, all of you. It's interesting to see. I mean, I presume you all are seeing my slides. Yeah?
Not yet.
We are seeing your beautiful painting behind you.
I thought I've shared it. What
No,
am I
can't
doing
see.
wrong? I'm screen sharing.
I don't know. When you shared, we were seeing twice, two doubles. Again, we are
Okay.
seeing two of us when you are sharing.
Okay. But then are you now seeing? Are you now
Not,
seeing?
no, same. Dr. Anita, you have minimized your slides now.
I have minimized my slides, so that's what now?
I think you're sharing your screen again and again.
Okay.
Not yet.
My desktop, you can see?
No, we are just seeing ourselves.
Oh, we can't see the desktop.
So can I get some?
That too, we are also
Ma'am,
still.
please stop sharing right now.
You stop sharing, they'll connect you.
Huh.
Stop. I've stopped. I've stopped sharing.
Now
Now
your file is open, the PPT is open.
I have to minimize. Yes.
Minimize, then share, and then you will see
Click
your
the share
screen.
button.
And then do the slideshow.
Then you can select that.
We yet have to see the slides now. We
Then you
can't see it.
press the share button, select the slide, and then you press the share button.
I've minimized Zoom meeting.
No, don't minimize the Zoom meeting. Otherwise, you will not be. Do not minimize the Zoom meeting. Let the Zoom be big.
So I'm now doing share.
Just share and
Now-
then see your.
Yeah,
Now we can see it.
Perfect, ma'am.
Thankfully, sorry. So I think that it's been quite interesting the way first trimester screening has developed. So I absolutely agree that it's still very fundamental, and I think training and doing the NT, understanding biochemistry is absolutely important. But as you rightly said, Archana, we are holding more and more programs through FMFI India Trust to get the certification, because we understand it isn't just about aneuploidy, it is much more. And this is what I wanted to at least throw in the air and kind of get feedback from all of you, because now when we're talking beyond NT, I'm going to just discuss some of the concepts which have come from Professor Nicolaides, where he's talked about prenatal care of 2026. So we have discussed the chromosomal abnormalities, but he believes that all these other things can also be done, and this is what prenatal care in 2026 should be all about. So I'm going to just pick up a few things. I mean, some of he's added maternal depression, and that in the first trimester should we be handing out a survey form and to assess women's mental health and things. So that's also now been included in our 11 to 13 week scan. But let me just discuss the more important ones, which is that NT, which I know all of you know, and I'm not going to tell you how to take NT, but we are moving more and more towards looking at structural abnormalities. And the things that we were doing in the second trimester, that means that we're looking at the transventricular plane and the transthalamic plane. That is the things we are doing again, because you can see very clearly that you can see the butterfly sign, but you can also now go beyond that and look at the cerebral peduncles, and go even beyond that to look for the cerebellum and identify if there are posterior fossa malformations, or at least get a suggestion that these patients need to be followed up. Things like anencephaly, I mean, they should be diagnosed in the first trimester. It's a thing of the past for us that we pick up these kind of problems in the second trimester because the views are so good. Exencephaly, where you have just no skull and you can only see the brain, versus anencephaly, where the brain has completely dissolved and you have the classic frog sign. So these things are really easily picked up, and you can see, they were seen much more. Encephalocele, which is a protrusion. Again, if you look, because one of the things we look for in the first trimester is the skull bald being intact. You can make out if it isn't, and you can pick up the occipital encephalocele again very, very early. Holoprosencephaly is another really important brain abnormality where the division of the prosencephalon hasn't happened that well. There are several types of it, but the A-lobar type, which is the most severe, where you just have a monoventricle, you just have a single ventricle. Again, this is a very obvious diagnosis in the first trimester. So similarly, there are other defects, including spina bifida, which is what we are struggling with still in our country, that we, neural tube defects. And again, if there are really obvious spine lesions, one can find it. So there is a checklist of how you do the anomaly, early anomaly scan. That means the 11 to 13 weeks anomaly scan. I'm not going to go through it because of the time, but I thought let me just cover the brain and the heart to show you how much things have progressed and how much we can do. So it is mandatory that you do a second trimester, mid-trimester heart view. And these are the very standard views that we have. But we are saying that you can apply these in the first trimester cardiac screening planes as well. So you can, I mean, this fetus is 12 weeks. One day you can see that there is a biventricular heart, and you can look at the outflow tracts as they come out, that the aorta and the pulmonary are crossing over, and they are forming a very nice, they're coming into the neck very, very nicely. So at least you can make out that there's not like a single ventricle, you don't have outflow tract major disorders. So at least these are things that we can do. So according to Professor Nicolaides, who's done a lot of research on this, if you look at fetal defects by the end of pregnancy, technically we agree that the majority, so totally in an entire pregnancy, you may have about 2 to 3% have actual abnormalities. Why we see so many is because our population is so huge. But actually, the thing is that you would expect things to go normally, and it's only maybe in about 2 to 3% that there are fetal defects. And we have just focused on the mid-trimester as being the anomaly scan. But this data proves that you can even 0.6 of that entire gamut of those 9 months, you can pick up about 0.6% of the abnormalities in the first trimester. Okay, a lot in the second trimester. But now for us, our third trimester scan, which till now used to be just a growth and Doppler scan for us, has now been converted again into an anomaly scan. So really what we're doing now is screening for abnormalities in all the 3 trimesters, because things like microcephaly or cardiac defects we may have missed, or renal abnormalities and certain brain defects can be identified mainly in the third trimester, or being picked up very easily in the third trimester. So therefore, for us now, the message that's going out is that actually you need to be looking for abnormalities in every trimester. It is not the mental mindset that we have that it has to be mid-trimester is kind of gone now. As you understand, the whole ethos of FMF is to give patient-specific personalized risks. And these are for aneuploidies, which Archana had discussed with you, but they've also been one of the sort of frontiers for preeclampsia screening. And we've added FGR screening as well. And the point is that the best thing to do is that you do everything, that you take a history, you do mean arterial pressure, you do the uterine Dopplers, and you do the biochemistry. So this is the ideal, you do everything. But we recognize, and people recognize, but that is not the reality on the ground. On the ground, the reality is that you may have to do a combination of any of them. And this research paper is showing that even if you just take blood pressures, there you will be better than just using history alone. Or if you do blood pressures and uterines, you will be better. You'll be very good. Of course, the best is where you do everything, but the point is do something, use an algorithm, because the future is moving towards algorithms. It's not moving towards, sort of general risks. It is moving towards personalized risks. And the ones who have the risk, the women who have a risk of more than 1 in 100, aspirin needs to be started off. And this is taken till 36 weeks. And, it's thought, even with our data and our paper, that it reduces the risk of severe preeclampsia by about 60 to 70%. Now, the trial that's going on is the next study, where we indeed start aspirin, and we know that we are taking till 36 weeks. But the question arises that, say, when you come to the second trimester, because FMF says that you must look for preeclampsia and screen for preeclampsia at every trimester. So say at the second trimester, when you screen this woman, looking at other markers, her risk actually now is low. So does it make sense that the ones that we started in the beginning of pregnancy, can we stop aspirin mid-trimester? Is it good enough? Or do we need to continue right up to 36 weeks? So I think this would also be very interesting to see what's going to happen here. We know that actually the best thing, and what uterine arteries and the blood markers and the history, it's best for preeclampsia, that we know. But the thing is has it got a role in screening for fetal growth restriction as well? Can we, in our first trimester, predict who are the babies who are going to land up as FGR babies, or at least severe SGA babies? So it is true, it is not as good. I mean, there have been several studies which have looked at uterine artery assessment and how good are they at predicting FGR, and it's a poor standalone screening test. So just doing uterine arteries is really not good enough. However, in 2013, Leona Poon and the FMF group looked at combined screening. That means that they looked at, if you use uterine arteries along with bloods, how good is it in predicting SGA? And they found that it was about 50-55% efficient. So at the moment, we are doing it. We do predict FGRs. We tend to call them back early. We use this model because we do universal PLGF, but even if you don't, again, do something. And on this, you can predict at least half of the people who are going to land up with SGA other than preeclampsia. So you have the preeclampsia cohort anyway, that there is an overlap there. But the cohort which don't have high blood pressures, but yet are small, can they be picked up? So the first trimester takeaway as far as FGR is concerned is you cannot use Dopplers on its own, and it needs to be, as Arshna said, as part of a multimodal screening algorithm. The other thing that is kind of being changed and which is coming through FMF is that should we be what should we do about gestational diabetes? So it is thought that the fetal pancreatic function develops at 20 to 24 weeks. So therefore, if we identify the women who are prone to have gestational diabetes and kind of put lifestyle changes or medicines or whatever in place before 20 to 24 weeks, before the pancreatic function gets affected, this may be better for the patient than what we are doing at present, which is that our main time for screening is mid-pregnancy. So the OGTT is what we do, but FMF is proposing that we should be doing, perhaps considering doing a CGM at 12 weeks, because this is more physiological than doing a 2-point test or a single point test or a 3-point test. So if, say, you put on a CGM sensor, which for 2 weeks, as you know, it's now easily available, that if you use it for 2 weeks, it's more likely to predict who are the ones who are going to have GDM earlier than our current screening methods. So this is something to be thought about. I mean, I've discussed this with my endocrinologist colleagues, and they're saying that, look, this costs 5,000 rupees, and are you going to do a screening of 5,000 versus a simple blood glucose test, which costs a couple of hundred rupees? And there's not going to be that many takers for this idea, at least in India. But I personally think that intuitively it makes sense to me, actually, because of course it's more physiological if you look at it. And the other thing is women also would prefer it. I mean, I think glucose sensors are really very common now. And it is important for us to address the problem because of the long-term cardiometabolic abnormalities that these women can have. The last thing that I thought that I would discuss would be, should we be screening for CMV in the first trimester? We don't. I mean, all of us know that we don't actually screen for CMV. But new information that has come in is that where earlier we used to sit there and think that, okay, infections happen once the woman gets pregnant, but in CMV, even 4 to 11 weeks before her LMP, if she's been exposed to CMV, there is a likelihood that she can have an infected fetus. And we know about the first trimester anyway. So this is a very vulnerable period. We know that 50 to 60% of congenital CMV are born to mothers with non-primary infection. So again, we used to think that, okay, it's only primary infection which causes the problem. We know that in CMV, the vertical transmission rate is low, but the reality is that we are so many of us, and so many of us have got, the CMV seroprevalence in our country is so high. that if you look at the pediatric population, the sort of 3-year-olds, 4-year-olds, 5-year-olds who've got sensory neural deafness, and if you talk to your ENT colleagues, 2/3 of them have had thought to be infants where the mothers had already pre-existing CMV immunity. So the point is that should we be screening? And I think, again, if you're not looking at costs, then maybe this is something you should think of because of the fact that now we have in utero medical therapy. So if you just wait for maternal history or look for ultrasound findings, only about 10% of women will give a history of fever or headaches or flu-like symptom. The majority are asymptomatic. So we need to have a policy that we do bloods and look at serology. And this paper is so clearly proven that if you screen at 11 to 14 weeks and treat women who are screened positive with valcyclovir, then in that group, they had 0% mental retardation, 0% seizures, 0% chorioretinitis, but the only thing was hearing loss, which is treatable. So the ENT people can treat the sensory neural hearing loss, as opposed to this, which is without treatment. So it is something for us to think about, that should we be screening for infectious diseases? We do it for all of this, but should we be also doing it for CMV? Archana was alluding to the FMFI trust. This is now a UK authorized examining body. That means that professor has authorized FMFI trust to actually issue out the certifications and examine. So if any of you are interested in getting your NT certification and indeed hearing more on this lecture, because it's really quite fascinating. So his professor's whole lecture is on this website. So if you have time, do go to FMF India.in and listen to a more detailed lecture from him on where prenatal care is going, and to get certified. It would be very good. So thank you, Archana, very much. I'm sorry for the mix-up with my PPT, but really I do wish you well. And as Shelley said, I think you'll be amazing as a president because you're such a team player, and I'm sure you'll take things forward. So we are sending you a lot of positive vibes and encouraging people to vote for you as well. So thank you very much.
Thank you, ma'am, for the informative session here. I request our chairperson to kindly share their remarks.
I think, Anita, it was a wonderful talk, and you said rightly about the screening of CMV infection, but, honestly, you suggest at 11, 12 weeks, or you'd suggest at first visit?
No, when you're in your booking bloods.
Yeah, and booking bloods. And, there's so many times, most of the times, I will say 80, 90%, they're already IgG positive and IgM negative,
But
and
still, it's
yeah.
best to
So,
check.
yeah, but I
Because
feel if you don't do
us-
for everyone, I think at least everybody gets so many doctors, nurses who has previous children, one should screen for them. Because recently I got a doctor who was positive for, not CMV. She was positive for toxo IgG and IgM with a borderline avidity. And I did her test when she came to me. She was 12 weeks. Very difficult to give an answer when it has happened. It's just that
Yeah, but
time,
you know that you can treat it, no? Toxo
Yeah,
and
yeah, yeah, yeah,
yeah, no, that's true. So that's why it's a debate.
yeah.
Jharna wants to say something. Yeah, thanks.
More the test, more is the debate.
Yeah.
Pandora
No
box.
test, no treatment, then you suffer.
That's true. But I think we have to draw a middle path. No, life mein too much is not good, too little is not good. You have to have a right things.
But there is no middle path. That's a problem. Science is not a gray.
Yeah.
It's never a gray,
But if you look at the ENT surgeons, they always talk about the sensory neural deafness, and they really get a lot of patients. I mean, young children after 3 years coming up with that, and they still say, "Please do this test to see in your antenatal period." I mean, we can at least decrease the sensory neural deafness because children who are having sensory neural deafness, it's very difficult for them. They have difficult to read, difficult to learn, and again they have to run from one man to the other. So I think it's always better, and it's not a very costly test. We can afford that.
I think it's quite fascinating, our field, and the new things which are coming up, and for us to reflect. So maybe on a RCOG wala point of view, perhaps we can do things because perhaps we are much more in the private sector, whereas maybe in the public one has to be a bit more pragmatic. For me, I don't see why we shouldn't screen, to be honest.
And the
I
same
think
being
Dr.
in the
Anita
private sector, I do for everyone.
we have treatment now, valacyclovir. So I think
Yeah.
we can now start. Earlier we didn't have the treatments.
Yeah.
If positive, what next?
What's
So
the
now with
success of
the
the treatment with the L-cyclovir?
Very high. I
Uh-huh.
showed
And the
you that
treat
slide.
and
So
what's the dose like?
8 grams per
8
day.
grams per day.
The dose is a little high, but even if
No,
the
but people take it. It rarely gives any side
And
effect.
you continue till the baby is born, means.
Correct.
and
It's
even
throughout
if,
pregnancy.
Why
yeah,
not? If it prevents hearing loss, if it prevents the scissors, then why not? It's
Yeah.
such a big thing,
Actually, Dr. Angela, nothing is 100%. Actually,
No,
CMV
nothing
treatment
is
is very
100%. Counseling and treatment.
counseling is very difficult.
Counseling and,
CMV.
why not? Even if you prevent 5%
Yeah,
or 10%
that's
of
true.
it, it's a big deal.
no, but
Yeah.
the surprising thing is if babies are having seizures or they have something in the brain due to CMV, and even if they are treated with valacyclovir, they do respond. 100% they do respond. They do not have seizures. So when these babies do respond, they actually identified early because I've seen some children coming at 6 months, some children coming at 8 months having some lesion and having seizures. They present as seizures. They all get treated very well. So I think giving it better, the result is really good.
I think we need more experience. I think with time
Yeah.
we'll have more. We don't not treating so many mothers.
Agreed.
I think I would agree. Like diagnose and then treat. It is important because sensory neural loss.
Actually, we are treating when already baby has the sequelae in the form of ultrasound. We're not screened earlier. So when we see the calcification, then we go ahead and do, and then we diagnose. So it's already done. Harm is done by that time.
But no, the point is that even if you pick it up late, say
Then
middle
what?
The
of
harm is
winter,
already done.
no, it's not. It's
You prevent the harm. Actually,
preventable.
is the
You
direct
prevent
correlation.
problems. So if you start
Okay.
even at 24 weeks, I've started at 29 weeks and the baby was fine for brain
Right.
abnormalities and calcifications. So start treatment but don't terminate is the message.
Very nice.
Thank you, girls, Anjum and Rupali.
Thank you, Anita, for very insightful talk. Really enjoyed it.
Thank you, ma'am. We now come to the final scientific presentation of the evening. I request Dr. Angela Aneja, ma'am, to kindly invite Dr. Upma Saxena, ma'am, for the next talk.
Can you just put her CV on?
I think, Dr. Angela, you know me well. Just 2 lines is enough. You're muted, Dr. Angela. You're muted.
I will. Yes, Upma, we all know you very well and you are doing a wonderful work in Delhi. Dr. Upma is a professor, consultant, and head of unit at Vardhaman Medical College and Safdarjung Hospital. She is in charge of fetal medicine and genetic clinic, and she is a chairperson, fetal medicine and genetics subcommittee, AOGD 2025 and 27. And I will I will say she's doing a tremendous work, and we are
Thank
having
you.
so much of good conferences under her role. I hope we will keep on continuing having it. And
Thanks,
over
Dr.
to
Angela. That appreciation means a lot to me from you.
thank you. Over to you, Upma, now.
Welcome,
I'm
Dr.
sharing my
Upma.
slides. Can you see my slides?
No, not.
I
Yes,
no.
it's there. It's there.
Yeah.
On
You
screen,
can.
make it full.
Yes, we can see.
Okay. So, good evening, respected chairperson and dear friends and colleagues. At the outset, I want to thank Dr. Archana for giving me the opportunity. And I wish her all the best for the presidential elections coming in August. So
Thank you.
I think you are the right candidate. You have all the qualities whenever I had interacted with you. So going ahead with my talk, I'll be talking about challenges and dilemmas in fetal intervention therapy. So I had prepared my talk earlier, but I was told it's focusing more on the first trimester. So I'll be talking more about CVS than amnio and intrauterine IUTs. So whenever we do a fetal intervention, we are treating both mother and the fetus simultaneously, and that leads to a lot of psychological challenge, both for the patient and the operator, and also technical challenges, which I'll be talking about. And also there is consent and timing dilemmas. The main problem is who should advocate for the fetus, and we want to balance between doing good and not harming for two patients. And it is very debatable whether to keep maternal autonomy or fetal interest and viability threshold as primary. So we have to balance maternal bodily autonomy against potential fetal benefits. So main problem arises when this diverges between maternal and fetal well-being. And when we work for the best interest of the fetus, then we have to weigh uncertain outcomes sometimes and whether fetal interest can override maternal autonomy. So the psychological dilemmas is that the parents, they are experiencing intense anxiety, fear, grief, and uncertainty because of the emotional weight of the diagnostic results, procedural risk, and waiting period. And they most of the time they experience anticipatory grief, difficulty bonding with the pregnancy because they don't know whether it will continue till term or not, and strained relationship as they navigate uncertain outcomes. So what we need is a multidisciplinary care team, and we have to early integration of mental health professionals and support groups. So psychological counseling and social support service play a critical role throughout the fetal intervention process. Another problem is when there's lethal fetal condition, which we are diagnosing in first trimester and abnormal genetic testing, then we have the dilemma of termination of pregnancy. And we all know that the family is under great emotional stress. So we must navigate sensitive conversation about all options, including continuation of pregnancy with palliative care planning or termination where legally permitted. We all know that less than 24 weeks, we can just terminate for the life-threatening anomalies, and beyond 24 weeks we have to send to the medical board. And again, that's the catch. So gestational age affects both legal options and medical procedure available, adding complexity to already difficult choices for the family, because we as a doctor also keep telling, yes, we want to confirm the diagnosis, whether we want to go ahead or we want to terminate before 24 weeks. So when there's a severe anomaly in one fetus of a multi-fetal pregnancy, then the ethical dilemma is selective reduction. So the decision must weigh the interest of affected and healthy fetus against parental values and beliefs. Sometimes some societies, they don't believe in termination of pregnancy. They don't want to terminate their child. So selective reduction in multi-fetal pregnancy require careful consideration against type of twins, because we know if it's a monochorionic twins, we can't put KCL. We have to go for RFA or microwave ablation. And again, gestational age. Most of these procedure which we do for monochorionic, it depends on the gestational age of the baby and also potential impact on the surviving fetus. And again, the procedure itself carries risk to the remaining fetus, including there's a risk of preterm labor and pregnancy loss, which we have to counsel. So what we should do is we should go for a non-directive counseling and which helping shared decision making. Sometimes patient decline, then we have to respect their refusal, and we have to ensure documentation and provide them with follow-up and ongoing support. Then informed consent should include understanding of the procedure, potential risk benefit, and alternatives. So if I'm offering CVS, I can tell them that even if they don't want to get it done between 11 to 14 weeks, they can, after 16 weeks, they can go for amnio. And again, the patient's emotional condition is very sensitive. So the healthcare provider faces the challenges of ensuring informed consent when outcomes are uncertain with finding of WUS. So sometimes they go through all the procedure and then the finding comes at variant of unknown significance, again complicating our counseling further. So there are also technical challenges because we all know that fetal intervention procedures require highly specialized technical skill with a steep learning curve. And for that, the operator should have extensive hands-on experience. And when we are doing all these three procedures, it requires precise ultrasound-guided needle placement and real-time decision-making. And the operator experience directly correlates with procedural success and also reduction of the complication rate. So how can we build expertise? It can be done through fellowship programs, simulation training programs, and structured mentorship. So in Safdarjung Hospital, we are lucky to have so many patients, but in private setups, they don't have so much. So all of these are required so that our fetal medicine specialists, they get more confident with doing these procedures. So besides this operator skill and training, we also need good ultrasound machine. And now with the maternal BMI increasing, sometimes doing a simple amnio becomes difficult. You have to ask someone to pull the abdomen fat first, then only you are able to do the amnio. Then fetal position, placental location, whether it's anterior. When amnio, then we don't want the placenta should be anterior because we don't want to go through placenta. While in case of doing a CVS, definitely anterior placenta is much more easier to do a CVS compared to a posterior placenta. Then there is a timing dilemma because we know that for every intervention, there is a gestational age window, and sometimes repeat procedures and adds the cumulative risk. Then there is also challenges in management of the complication because they need a critical response protocol, and rapid recognition and intervention prevent serious outcomes. So I was doing an IUT and I realized that there is a fetal tachycardia. So I immediately prepared the baby for section, and we were able to salvage the baby because most of the time for IUTs, we keep our OTs ready. So for that, we need a multidisciplinary team response. So we have to tell our pediatrician and our anesthesiologist that they may be needing an urgent surgery. So coming to the genetic counseling, the counselor should provide them about the test results, inheritance pattern, recurrence risk, and available options. So genetic counseling is integral to fetal intervention therapy, serving as the bridge between complex medical information and family understanding. They especially come when you get a report of WUS, then we want to counsel that what further. So because they have undergone a procedure, so they want to know how to go proceed further. So coming to the problem of new technology like NIPT, we all know that if we perform after 10 weeks, the detection rate for trisomy 21 is almost more than 99%. And it has so changed the indication for amnio and CVS. But we know it's a screening test, and if it comes positive, we have to go ahead to confirm it by doing an invasive test. Again, when we are counseling the parents for NIPT, we should know its limitation. It could be false positive due to confined placental mosaicism, maternal chromosomal abnormalities, or vanishing twins. Then besides the trained specialists, there is also dearth of advanced ultrasound machine, sterile procedure rooms, sophisticated medical infrastructures. So many families, they can't access life-saving intervention due to high procedure costs, inadequate healthcare system, and limited referral network, raising serious concern about healthcare equity and justice. So we were just talking about the aneuploidy screening. So in first, Dr. Archana just talked about that in first trimester combined screening, you will look for maternal age, ultrasound for NT, serum biomarkers like beta HCG, free beta HCG, and MPAP. And NT, we know it's done between 11 to 13 plus 6 weeks when the CRLS is 45 to 84 mm. So I just want to emphasize that when NT is increased, it is associated with many chromosomal abnormalities, genetic syndromes. So coming to this case, this primary gravida, she came to us at 12 weeks. So in my clinical practice, I always ask the patient to go for this combined first trimester screening at 12 weeks because we know the window is 11 to 13 plus 6. But at 12 weeks, we are able to diagnose many anomalies which Dr. Anita was just discussing, and also it becomes better, and your biochemical test also have a good result window at that point. So here the NT, Dr. Archana was telling, anything more than 3.5 is considered as 99 centile, and always whenever we do NT, we have to see the POG and we have to calculate the centile. Any NT between 5th to 95th is normal, and more than 95th is abnormal. So, and whenever you see a report of NT which is abnormal, you should check whether it has been done properly. So just looking at the ultrasound image, you can know whether the right magnification or mid-sag view was taken or not. So I just told that if NT is increased, it is associated with aneuploidy, genetic syndrome, infection, and structural anomaly like heart defect. So the message should go is that thickened NT should be taken like a structural anomaly, which we were talking like holoprosencephaly and your other defects, and it's an indication for doing a invasive testing, that is doing a CVS, because CVS when done between can be done anytime after 11 weeks till 14 weeks, and will help us a early diagnosis, so which will help in shared decision making. And the test done ideally for all anomaly including thickened NT is your microarray, and if it comes out and with DNA storage. Why DNA storage is because if microarray comes normal, then it could be, and thickened NT may be associated with some genetic syndromes like Noonan, so which can be diagnosed or picked up only by doing a whole exome sequencing. Coming to the CVS, we all know that it is performed between 11 to 13 plus 6 weeks. We don't do before 11 weeks because it increases the risk of limb reduction and oromandibular hyperplasia. And it gives us information early. Now with the timeline of, and especially it is very good for when we are looking for your autosomal recessive disorder like SMA and your thalassemia, and can be performed transabdominally or transcervically, but in our hospital we are just doing it transabdominally, we are not doing transcervically. So comparing CVS with amniocentesis, we have to balance time advantage, that is with CVS, against the risk of your confined placental mosaicism. In here, the placenta will be abnormal, the fetus will be normal. So your report will come as abnormal. So we don't know, so you have to do amniocentesis later date to know whether the baby is really affected or not. And the fetal loss is similar with both CVS and amno in a experienced hands. Indication, we all know whenever there is abnormal prenatal test screening, or we want to look when the parents are carrier of autosomal recessive disorder like SMA and beta thalassemia. It cannot be used for neural tube defect. So coming to the dilemmas, the miscarriage rate is little more than amnio because we are doing it at an earlier gestation and it is a placental sampling approach. And here we use a 18 gauge needle, as you can see here, which is passing through the anterior placenta, and we move it 1 to 10 times back and forth using vacuum. And it's very important that we look at the number of villi. So the minimum amount of villi we should get in CVS to get an optimal report is 5 milligram, and so there is a sampling failure rate of almost 2.5 to 4.8%. So this is very important part of the counseling, because patient has undergone an invasive procedure, and if the lab shows that the sample is not adequate, then the patient will come rushing to us. So counseling is very, very important. And the confined placental mosaicism occur in 1 to 2%, which I have already told you requires amniocentesis at a later date. Vaginal bleeding I have rarely seen, but most of the literature quote is 10% and is seen more in transcervical, and amniotic fluid leakage is very, very rare. And according to the most of the studies, the fetal loss is almost similar of CVS is almost similar to amniocentesis, and we have to counsel the parents regarding confined placental mosaicism and MCC, which most labs are doing. Coming to the technical challenges, it is difficult to do it when the uterus is retroverted or there is a posterior placenta. And the other problems are inadequate sample, repeat procedure, subchorionic hematoma formation. And whenever we are doing it for a thickened NT or a structural anomaly, we should tell the parents that by itself, the pregnancy is at a higher risk of miscarriage, so that they don't blame it to the procedure. And sometimes there is a culture failure In case of multiple gestation, there is a risk of cross contamination. So how can we avoid it? So when we are doing it, then we should take the biopsy near the placental cord insertion, and we should avoid the intertwin membrane. And most of the studies say that we have to aim for contamination of around 3 to 4% in case of twin pregnancy, and there should be proper counseling, because in case there is some controversy, then they may need an amnio at a later date. Coming to amniocentesis, we know it's the most commonly performed invasive procedure, and it is performed beyond 15 to 16 weeks. And here we take 20 cc of amniotic fluid, which provides us enough viable fetal cells for accurate genetic and biochemical analysis. So we have to weigh diagnostic benefits against the procedural risk. And with the advancement of NIPT, the number of amnio has decreased, but it has increased the dilemma regarding when conformity testing is truly negative. It's truly necessary. So, and when we all know that if NIPT is a screening test and if positive, we have to go ahead and confirm it by doing the invasive testing. Another problem is the timing dilemma. So if we do early amniocentesis, then there is a higher complication rate and telepus. And best time is to do mid-trimester. Most of the private practitioners, they say 17 weeks is better because at that time there's maximum safety and also sufficient amniotic sample with a good cell culture. And we should do this procedure only where there's amnion chorion fusion, because if we do it earlier, then it will lead to fluid leakage and failed procedure due to tenting. Coming to needle size dilemma, in our hospital, we are using 20 gauge because most of the studies have found that 20 gauge is associated with faster fluid retrieval and the safety profile is same as your 22 gauge. The miscarriage rate is quite low in case of experienced hand, and another important risk is a history of preterm prom, the occurrence of preterm prom, which occurs in 1 to 2%. But here the risk, the outcome is much better than the spontaneous prom, because many a times the membrane resealing occurs. Risk of choreo fetal injury is very, very low. And other important factor is that we don't want to traverse the placenta because it increases the risk of fetal-maternal hemorrhage. So whenever we are doing in an Rh negative mother, we try to avoid, and usually we are able to find the window. But in case we have to, then we always, whether we go transplacental or not, we have to give them anti-D prophylaxis. And then another problem is maternal BMI. How can we reduce the risk? We can reduce the risk if the person doing 100 procedure per annum, then the risk of complication or fetal loss will reduce. And also the risk increases when you do more than 3 attempts, there is a blood stain, amniotic fluid, or there is a fetal abnormality. And if there are more than 2 punches are necessary, then we have to delay the process by 24 hours. We have to do it next day. There could be a failure of amniocyte culture, and it occurs mainly when there's a blood stain like a maternal cell contamination and late gestational age. So we can do it at a later date also your amniocentesis, but as the POG increases, the risk of culture failure, it increases. And we can, sometimes we see amniotic cell mosaicism and WUS, which I was talking. Coming to the technical challenge, in multiple gestation, there's a complexity. Sometimes you can sample the same fetus again, and there could be labeling errors. When you're doing it with the baby with the anomaly, you want to make sure which sample you take it from the anomalous baby and from the normal baby. So we can avoid sampling the same fetus by keeping in focus the intertwin membrane while sampling, and also putting air bubble after the sampling first twin, because we can see that and we can just know that we have already sampled that baby. Then again, other problems are anterior placenta oligohydramnios. So sometimes in case of oligohydramnios, especially renal agenesis, we have to go for placental biopsy. We are not able to do amniocentesis. Coming to the IUD, we all know that it is done for RH isoimmunization and parvovirus B19 infection. But the indication has increased now further to TTTS, chorioangioma, fetal sacrococcygeal teratoma, CMV. So I had recently did it for a chorioangioma and they had gone home with a healthy child. So we all know that we have to do MCA PSV to diagnose fetal anemia. The challenges of MCA PSV, that angle of insinuation should be as close to 0 degree. It can be done only between 18 to 35 weeks, cannot be used after 2 IUDs, and already it's difficult, it's not much very reliable when the baby already has hydrops or they has fetal brain anomalies. Another challenge is which route to do. So usually we go either intrahepatic portion of the umbilical vein, and this usually we do when the placenta is posterior, and when the placenta is anterior we go for the umbilical vein as is placental insertion. Some people do free loop of cord, umbilical cord, but that is quite dangerous and should not be done without paralyzing the fetus because it leads to cord hematoma. And sometimes we are not able to do anything, we have to go for intraperitoneal approach. So this is the slide showing how you're going into intrahepatic part or the umbilical vein, and here you are going into the umbilical vein when the placenta is anterior to the transplacental route. Here you can see the blood flowing. We are doing it to the transplacental in the umbilical vein, and this is in the free loop of cord, which should be avoided. So we do it rarely when we are only after paralyzing the fetus. So intraperitoneal route we are doing when the baby is small, 22 weeks, and the advantage of doing the intraperitoneal route is the rate of fall in hematocrit is just 0.01%, and the blood is absorbed slowly over a period of 7 to 10 days through subdiaphragmatic lymphatics. The only problem is it's not very helpful when the baby already has head drops. And we are doing combined approach also. We are putting intravascular and also intraperitoneal. Intracardiac, we rate extreme condition. So what is the advantage of intrahepatic approach? That is considered to be the safest because here we are just putting in the hepatic vein, and so there is no chance of puncturing any artery, which we can do in case of your transplacental route, and there is also no risk of secondary vasospasm, cord tamponade, and fetomental hemorrhage is least. Other problem is how to calculate the transfusion volume, because there are multiple formulas for that. Donor hematocrit. So we are doing point of care test, and most of the time in South Indian hospital, the hematocrit is 75 to 80%. So we always do it to check because that helps us in calculating the blood volume which we have to give to the baby. Then we have to balance between treating anemia and avoiding circulatory overload, because these anemic fetuses already are they are having cardiomegaly and cardiac failure. So we have to avoid circulatory overload. So we have this Mandelbrot formula, we have this perinatology.com formula, then we have SFM formula to calculate how much blood to be given. Again, problem is what should be the target hematocrit. So depending on the period of gestation, usually if in second trimester we keep it around 45%, and more than 28 weeks we keep the target hematocrit around 50% because we need it for calculating the blood volume. Then the challenge regarding the first IUT timing, because if we do intervene too early, then it will increase the procedure risk, and if we delay, then it will lead to irreversible fetal damage such as hydrops fetalis and cardiac failure. So we have to balance early intervention versus procedural risk. Another problem is that IIT has this inherent procedural risk like fetal injury, sensitization, and cumulative transfusions can lead to cumulative problems. So we have to balance the risk against the severe fetal anemia. Then there's a blood product selection dilemmas. Then how to decide when to transfuse once we are given one transfusion. So we usually follow that there's a fall of 1% hematocrit per day in case of a intravascular transfusion, and so we plan our second, third, and subsequent on 2 weeks, 3 weeks respectively. Then we have to monitor for hydrops, then plan the delivery, when to deliver. That is also very, and sometimes baby, whenever we are delivering these kind of babies, we know they may need top-up transfusion and they may have delayed anemia because of the bone marrow suppression. Acute complication, I've just told you, we have to be ready with or keep the OT ready. We give them dexamethasone for lung maturity, and we have to look out for fetal bradycardia in between transfusion because it could occur because of the rupture, spars, tamponade. There could be preterm rupture of membrane, fetal death, and most of these acute complications depends on operator expertise. There are many studies which have shown that the neurodevelopment outcome is almost 95, good outcome in almost 95% of the children, but they could be associated with neurodevelopment impairment if there is severe hydrops, if the baby needs multiple IUTs and severe neonatal morbidity. So how can we reduce complication? We can reduce this by more doing intrahepatic approach rather than transplasant and transfusion. We in our hospital we are cross matching the maternal blood with the blood which we are transfusing, and we can, if we can use single donor for all our IUTs, and we should avoid free loop of cord. So by using fetal paralytic agent, cord accident can be avoided as it prevents needle dislodgement from fetal movement. So it's very important. So while counseling the hydrops, we have to tell them that in a hydrophic fetus, the response rate is just 94%, and there's a technical difficulty with ascites and higher complication rate. The last part is how to time our final IUT. So we have to balance procedural risks against prematurity complications. So ACOG says that you'd give last IUT at 30 to 32 weeks and deliver by 30 to 34 weeks. That is a two preterm baby. But SMFM says that you can final IUT can be given till 34 to 35 weeks, and we can plan delivery at 37 to 38 weeks. Many new studies are coming, and where the authors found that extending IUT beyond 34 weeks in selected cases is safe and is associated with improved obstetric and neonatal outcomes. So to conclude, all these fetal interventions, technical expertise is needed, and for that we need more case volume. And each procedure carries unique dilemmas requiring individualized approach. Multidisciplinary collaboration improves outcomes. So we have to rope in a geneticist, we have to rope in a pediatrician if you are doing IUT, and honest balanced counseling is essential. So whenever we are counseling, we tell them the no test is 100%. So if we do one test, it will just, if I'm doing a microarray, it will just tell us deletion and duplication. It will not tell us about single gene defect. And if we're doing 4 whole exome sequencing, it will not tell us about your deletion and duplication. So that is very, very important. So counseling helps in informed decision making by presenting all options without bias. Emotional and psychosocial support should be provided throughout the diagnostic journey, helping families navigate uncertainty, grief, and the complex choices that may follow abnormal findings. So thanks a lot for the patient here.
Thank you, ma'am. I request our chairperson to kindly share their remarks.
Thank you, Upma, for such a wonderful and elaborate, I will say, talk, So I think I will say I'm not a fetal medicine person, but I will like other fetal medicine specialist, Dr. Archana and to Anita to comment on that. Because we are totally dependent on you on this.
I think
your take, what till IUT you are doing, last IUT when you are doing, and when you are delivering. I think definitely I want to hear from you.
No, I mean, after the Delphi consensus came, so I don't know if all of you are aware, but there was a Delphi consensus, which is what are the guidelines that we are following as to when the last IUT should be there. And generally it's thought we should take the parents up to 37 weeks. So we do.
You believe in that?
Yeah. And we follow it also.
Because how you follow it? Because in our hospital, if you do IUT beyond 35 weeks, pediatrician is after your life. Madam, why you're doing after? Because definitely each IUT carries a risk. And yeah, with more experience, definitely depends on the expertise of
Yes, this is not a new thing that you are doing IUT for the first time in pregnancy. You are doing it on a regular basis. And one has to always, the pros and cons.
Yeah. So this
if we are able to take the baby 37 weeks, it will take care of ARDS and other kind of things.
Also, most of the guidelines says is PSU more than 1.5 beyond 35 weeks, you deliver.
Not the Delphi guidelines.
But your Delphi guidelines, because the older people are not familiar. The problem is our pediatricians are not familiar with those guidelines. They still go following those.
So
awareness has to be improved.
Because that's now the standard, no? But anyway, it was really thorough and really enjoyed it.
I think I really enjoyed the focus series where we have covered, I think, everything. I mean, most of the things, I should say, and good discussion also.
Thoughts for, how we should change our clinical practice as well. So that's also good to hear from colleagues.
Yep.
Great. Dr. Archana, all the best.
Thanks. Yeah,
Thank
really.
you.
We are
Thank
there
you,
with
Angela.
you.
Again, best wishes and
Thank you, Ma.
definitely doing good job.
Okay.
Thank you.
All
Thank
the
you so
best.
much.
Girls and
Thank you so much.
other members.
So I
Yes.
think now we have to propose vote of thanks. So
Hmm.
I don't know whether Anjum and Rupali are there, but let me.
Anjum is there.
Yeah, there.
They are there. So yeah.
I think Ankita will
Yes.
say the Ankita, can I request you for the vote of thanks? But they were all very wonderful lectures, ma'am. All the three for juniors like us, the clear-cut guidelines. We all enjoyed it thoroughly.
Thank you so much. And so we would like to thank. I would like to thank Rupali, Anjum, Nikita, and I would like to thank our speakers, Dr. Anita Cole, Dr. Upma Saxena, our chief guest, Dr. Neena Malhotra, and all three chairpersons, Dr. Angela, Dr. Sorry, I just in the middle of something. Yeah. So Dr. Shaili, and I think we should thank the farmers also for providing us a seamless platform here. So that was really very good discussion, and it is always there is a learning. So when you're with the colleagues and those all of them are doing the like one focus thing, it makes the program very successful. So I'm really thankful to all of you. You have spared your time and joined us, and I'm already getting the messages from people who have joined in. Congratulations for excellent webinar, super discussions. So people are asking for recordings as well. So I think that's a great feeling that we have done a good job. Thank you very much.
Thank you, ma'am.
I like your campaign. This is not a campaign poster, but it's a nice,
My journey.
nice, and I like the photograph. I
Thank
like
you.
the way you've done that.
Thank you so much.
Good.
Thanks a lot.
Okay. Good night,
Okay, good
everyone.
night, everyone.
Thank you, ma'am.
Thank you, sir,
So
for
stay connected, and we meet again at some other platform, right? So
Yeah.
we'll do much more activities like this in the future also. Yeah.
Okay then.
All
See you.
right. Thank you so much.
Thanks, Jarna.
Thank you for
Dr.
having
Jharna is there or she has left?
No,
Yeah, I'm
she's
also
there.
there.
She's there.
She's
She's there
always
from the
such a good
beginning. So Dr.
friend.
Jharna, very special thanks to you for really staying from the beginning of the webinar till the end of the webinar. So thank you so much, Dr. Jharna.
Okay, bye. Bye, everyone.
Bye bye for now and have a good
Good weekend. True.